Good afternoon and welcome to the webinar this afternoon. And thank you very much for participating. The webinar is being sponsored by the College of Nursing and Health Professions, as well as the Lewis University Nursing Alumni Network. The Lewis University Nursing Alumni Network, or LU-NAN, was established by nursing alumni and for nursing alumni to provide networking, mentoring, and continuing education opportunities for alumni of the nursing program at Lewis. Throughout this webinar, if you have any questions for our presenters, we'll respond to them at the end, but please feel free to email those questions to alumni@lewisu.edu. That's Lewis, L-E-W-I-S, the letter U.edu. If you are interested in continuing education contact hours, at the end of this presentation, you will be able to respond to a couple of post-test questions by emailing those responses to Nancy Peak, the Coordinator of Continuing Education at Lewis University, at peekna@lewisu.edu. The planners and presenters of this presentation disclose that there is no conflict of interest to reflect. I would also like to thank our presenters today, Ms. Linda Steffens and Dr. Belinda Wholeben, for presenting today. Ms. Linda Steffens is a member of the faculty at Lewis University within the College of Nursing and Health Professions. She is also the current president of the Lewis University Nursing Alumni Network. Dr. Wholeben is a professor of psychology at Rockford College.
Welcome everyone to our webinar. I'd like to tell you it was some of our research done on empathy that got us interested in this topic. This was a theme that came up in our research that we did on deferred empathy with critical care nurses. Okay, so topics that we'll be discussing today. First, we'll start with an overview of bullying and hostile interactions in healthcare. We'll talk about how nurses describe them, what researchers call them. We'll talk about the wounded workforce, those nurses who have been bullied, what this feels like. We'll talk about psychological perspectives, suggested multi-level responses to aid individuals who have been bullied, and we hope that you will send us in your questions so we can address those as well. Okay, let's start with our overview. I'd like to talk about some myths about bullying in nursing first. These aren't necessarily written anywhere, but they are assumptions that many people act upon. Number one, hostility is not prevalent. Nurses are just oversensitive. That really isn't true, and the research proves that out, that nurses take a lot before they even say anything. Secondly, targets deserve or ask for abuse. Smart people don't become targets. Again, not proven by the research. Number three, bullies are worth keeping around even if they won't change their behavior. Not true. It's not worth it. Even if they will come in at 10:30 on a Saturday night at 15 minutes notice to work, they have too much of a destructive impact on the environment. Number four, employers generally recognize the harm done to their organization and effectively deal with bullying. Not true. The next one, hostility is just part of the medical culture necessary to maintain quality patient care. The exact opposite is true. This hostility impacts patient care and patient quality negatively. Next, there is nothing that can be done about hostility in the medical workplace, and that also is not true. I have one more for you that is not on there. How many of you have heard that expression, nurses eat their young? This is something that we have passed along for many, many years in our profession, a little bit of cultural wisdom. And what's really interesting, even though I have never found this written in any textbook, colleagues from Poland, from Africa, from all over report that they have heard the same thing in their nursing education. They all have heard that nurses eat their young. And there's no denying the power in that message and no way to estimate how much bad behavior has been excused by it over the years. Here's a little bit about what we do know about hostility in healthcare. It's bigger than you think. It is more pervasive than you think. It's on every level, and it affects many, many of the key players in the healthcare environment. It's a system-wide problem. We're going to talk about it on a national level for the U.S., but really this is an international problem. It's been studied in Australia, New Zealand, England, Finland, and the results are all pretty much the same. Team members can function as both perpetrators and targets. We kind of take turns in both roles. This is especially true with nurses. It's described by many names, and the consequences are more severe than previously estimated. More than just the bully is affected, or the person bullied. Okay, let's talk a little bit about the behaviors that nurses identify as hostile in their workplace. There's the nonverbal ones, eye rolling, facial expression. There's overt or covert verbal affront. There's humiliation in front of others, an unfair workload, gossiping and backbiting, broken confidences, withholding information, that old adage, knowledge is power, scapegoating, someone taking credit for your work, and verbal abuse. When nurses were asked what bullying looked like in their work environment, these were the things that they reported. How big is the problem? It's huge. On the national level, studies reveal that 59% of all surveyed nurses say that they have experienced or witnessed bullying in their practice setting. And one interesting thing that Dr. Wholeben is going to talk about today is the effect of witnessing bullying, what impact that has on the people who witness it. It really will, it may surprise you. Another interesting thing that we discovered is that some nurses observed that they were no longer aware that they were even tolerating bad behavior. It just was business as usual, the normal part of their day. And also that many nurses who are bullied are reluctant to report it for fear of being considered weak. This is like the double shame of being bullied. Different researchers gave these behaviors different names. Farrell called it aggression. Griffin called it lateral violence. It's also been called horizontal hostility, mobbing, incivility, relational aggression, intimidation, disruptive and inappropriate behaviors. This next one is new, and I was really interested to read this one, shaming. This researcher looked into how bullying makes people feel ashamed on many levels, and bullying as the bigger overriding term to describe this behavior. Now you might ask, why do we have so many names for this? And I will tell you, it has been a problem in compiling the results. When so many different researchers call it so many different names, it's hard to really establish a good, solid research base. However, like a lot of the rest of nursing practice, research is a handoff, and different researchers, when they do their research, they are looking for a name that just completely and accurately describes what they have found. And I don't think that that's necessarily a bad thing, but we probably need to put all of this at least under one category. And it seems that in the literature now that the word bullying is being used to combine all of these different studies. Bullying is experienced at all levels in nursing, staff nurses up through senior leaders. And even though the awareness of bullying has increased since our first research, lots of bullies remain unaware that their problem is problematic. As a matter of fact, one research study estimated that 70% of bullies don't know it's them. And why is this important? Well, it causes nurses to leave the profession. I mean, can you imagine you have gone through all of that training, all of those clinicals, all of those hard classes, you've passed your NCLEX, and the work environment causes you to give up on your dream of being a nurse and leave the profession. It also affects nurses' perceptions of themselves. It increases burnout. It impacts their health, and it can even occur at the level where it registers as post-traumatic stress disorder. On the organizational and unit level, there are implications as well. Research shows that bullying leads to an increased intention to leave a current position and increased turnover, definitely a loss of productivity, and increased absenteeism. Now, on the national level, it gets even worse. Bullying is associated with poorer patient outcomes. It's identified as a factor in sentinel events, and it threatens patient safety. What nursing practice settings are affected? Pretty much all of them from what we found in the research. It's been identified in inpatient settings, outpatient settings, educational settings, and very interestingly, the other night when I was watching some students give presentations of their final RN to BSN practicum projects, one student did an educational awareness program on bullying in an office setting. She works for a pharmaceutical firm and notes that the nurses bully each other in an office setting, even removed from clinical practice. It's very interesting. You see this little illustration that we have here with all these little dotted lines? I think that's very telling about bullying in nursing, because we go back and forth between practice settings into education, out of education, inpatient, outpatient, home setting, and it seems that we bring this behavior with us wherever we go. Now we're going to talk a little bit about the experience.
And bullying is most acutely experienced at the individual level, so we want to spend some time talking about the experience of bullying or being bullied. Going to use the term mobbing in this particular instance. As Linda said, there are all sorts of terms in the literature for the occurrence of bullying. As we're trying to firm down some technology, or not technology, but some terminology, many choose the term victim to refer to an individual who's been mobbed. And by mobbing, we mean many in the work setting ganging up on a particular person. And in this mobbing, the word victim is chosen because we want to emphasize that the person who is mobbed really is receiving an injury. They're receiving an assault. And so that term victim, although not a very hopeful term, is needed to really emphasize the outcomes of bullying. On the other hand, it's probably better to think of moving on from victimization to talk about recovery and survivorship. So we'd like to put some emphasis on surviving the bullying and not just being the victim. We have a slide we'd like you to look at for a few moments and just take some time to think about, reflect upon, read these words that are the words of those who've been bullied. Leads to a depressed affect, doesn't it? To think about decreased work satisfaction, loss of social networks, loss of confidence, social isolation, self-doubt. Bullying is so intense that we found that when bullying stops, it's usually not because the bully stops, it's because the victim stops. And the victim of bullying, victims have given the following reasons for how and why the bullying stopped. We're going to call the victim here the target. The target quit. The target's work performance, interpersonal relationships were so affected that they were terminated. The target chose to transfer. And it turns out that when target individuals resolve bullying by losing their livelihood, giving up a previously desired place of work, they suffer emotionally from this. There's a strong perception of injustice. You know, life's not fair. The workplace is not fair. There's a strengthened belief in the unjust world. And then a loss of coherence. That's coherence of ego. It's coherence of who am I and why couldn't I make it in this work environment. There's also the financial impact. Job loss comes with the inability to provide for self and family, which you could see would lead to further psychological injury, loss of health insurance, some family struggles, which we'll talk about in a moment, concern about advancement, and then once again all of the hassle that goes through a transfer. Our culture is so full of having work as part of our identity, if not one of the major factors of our identity. When you introduce yourself to someone, what's the first thing you usually say? What do you do? And when you get the what do you do question and your work is a source of anguish for you, that can be a hard question. And it turns out that those of us with higher education and higher work commitment are those who are most deeply affected by the injury of bullying. If you look at the three work orientations, job, career, and calling, how many of us entered our profession because it's not just that we wanted a job, we wanted a calling. We felt called to help others. And when you are in a work life where you're fulfilling a call, but that's been disrupted because of hostility and bullying, it's even more injurious. When we go through psychological injury, we often turn to our friends and our family for support. But our interactions with our friends and family sometimes take negative turns. We sometimes lose our ability to have honest, good conversation, to be spontaneous, and to be close. Because we're so concerned with what's happening to us at times, we're not available to support family and friends. And when bullying is chronic, it turns out that sometimes family might not be available for support of us. You know, family, they know our vulnerabilities, they know who we are, and sometimes they can play into blaming the victim. You know, I know how you are, just take care of this. Or, you know, I'm tired of hearing about all that's going on at work. You know, just do something about it. Stop complaining. I don't want to hear it anymore. And that's the language that happens in families sometimes when an individual is going through intense bullying at work. The family also has concerns for financial implications of this bullying, especially when it's evident that performance is being affected. We think our coworkers would be responsive and would be supportive to us when we're undergoing a bullying situation, but sometimes coworkers don't intervene. Coworkers fear that if they step in, they may be the targets of the same fate. That if they associate with you, then they too will be the target of bullying. So there seems to be a distancing of those that you've been comfortable with before. Probably one of the most pronounced reasons that coworkers don't intervene is what we call diffusion of responsibility. I don't have to step in as a coworker to defend someone who is being bullied because someone else will take care of that. She has others that she goes to talk to, or you know, he will step in. I don't have to step in. You know, this reminds me of the very famous case of Kitty Genovese, who actually was beaten, stabbed, and eventually murdered by a perpetrator that we know that at least a dozen people knew that something was going on, that there was attack going on, and no one stepped in to stop it. And the basic rationale for this has been diffusion of responsibility. Maybe I did my part and I called the police, but I didn't step in. I did my part. Someone else is bigger and stronger and closer. They'll do their part. We don't feel the personal responsibility of stepping in when we should step in. Linda and I both together do research in empathy, and our specialization is deferred empathy. Deferred empathy is empathy that happens after the fact. So you can be in a situation where you probably should feel empathy for someone, you don't, and for whatever reason, it just doesn't strike you, but at a later time, you very much understand that you should have been empathetic rather, and regret that choice not to be empathetic. The reason I bring this up is that in a study that Linda and I did a few years ago, nurses wrote scenarios where they had experienced deferred empathy, and I think one of the most very poignant examples was of a nurse who had witnessed bullying of another nurse. And she stood on the sidelines and didn't really say anything, and then found herself even kind of chiming in a little bit here and there, and didn't think much about it, didn't think much about the impact on the target. But then not long afterwards, when the mob had finished with that victim, they turned to her, and they began to bully her. And she was so affected not only by the impact of the bullying upon herself, but thinking back to when she observed someone going through the hurt of being bullied, she didn't step in, she joined. And so she had to deal with that self-discrepancy, that who am I that I couldn't step in when I saw a colleague in trouble. And she was so troubled by the bullying that she'd received and her previous inability to stand up for someone who had been bullied that she actually left the profession. And as Linda talked about earlier, that's not an outcome that we want. We want people to be able to resolve these situations in a more positive manner.
Self-discrepancy is such a powerful concept for nurses. We have this ideal of who we want to be, who we aspire to be, and when we don't reach it, it can cause us to have terrible feelings of guilt. This population of the bystander witness to bullying is a very interesting research opportunity that we're hoping to pursue in the future.
Thanks, Linda. I just make one final comment, and that is that, in addition, coworkers who witness bullying often themselves suffer from stress, depression, and even anxiety. Another psychological concept that applies in the bullying arena has to do with the fundamental attribution error. And the fundamental attribution error is the concept that we attribute the results of the bullying to the qualities and action of the person, the victim, rather than to the action of the perpetrator or to the organizational context. So we might say, why did that person let themselves be bullied? Why didn't they stand up for themselves? It's a blame the victim culture. Instead of saying, what are the organizational circumstances that allowed this bullying to take place? What about the bully? What are the characteristics of that person that bullying has become the standard operating procedure? This fundamental attribution error also can apply to the perpetrator. When we see people who bully, we often think that that is a bad person. That's a person who's showing very negative, deep characteristics of the personality, where in fact sometimes the bully doesn't even know that she or he is being a bully. I get people to do what I want by being firm and by telling them what they need to do and by monitoring and perhaps becoming over-involved, which can be seen as bullying to the victim. So I'd like to bring up for sure that targets do not seem to be of a defined personality type. The problem is not always within or often within the victim, or perhaps we should say never within the victim. The problem is often within the culture, and that targets are often people who have been successful in the past. It's just in this particular instance, for some reason, they're not able to stand up against the bullying.
Another important thing to remember is that many people in a negative culture participate in both roles. They at times are the victim and at times are the bully. A very interesting study by the Institute for Safe Medication Practice of pharmacists lists nurses as their #1 bully.
Oh my.
Yeah.
Interesting. As far as responding to bullying and the effects of bullying at the individual level, conventional therapies can be very helpful. Making sure you take advantage of the EAP opportunities that you might have. Looking for supportive and symptomatic relief. And if you see, like the third point down is coaching, and I want to emphasize that this isn't just coaching in terms of, you know, what do I do in this situation? Why am I allowing myself to be bullied? It can be more about strategies. It can more be about career development. What do I want to do about this situation that I'm in? Is this the right place for me? Could there be a different place for me? Rehearsal is a very, very helpful technique where you and a therapist, or even you and a friend, it doesn't have to be someone who officially has the credential of being a therapist, even you and a friend or two practice. What can I do when this happens in my work life? We've talked about some of the impact on family, so sometimes family therapy is a good idea so that everyone can be better understood and their patching up of this incident can be dealt with. If you are a therapist, you should familiarize yourself with the bullying and mobbing literature. There is quite a bit out there that could be helpful. And we see a need for more research on personal strategies to treat the effects of bullying. And then we want to look specifically in nursing, not just generalized, but in the nursing workplace. When we look at workplace dynamics, moving more to the systems approach to therapy, looking at organizational history, what is it in the history and culture of an organization where bullying is tolerated, that it's allowed to happen? If one is the victim, or move to the word survivor of bullying, you also have to know your own organization. We're often coached to report this to the authorities, report this to your supervisor, but you always have to know the situation in which you work, and is this something that you feel comfortable doing? Are you with a leader who is using a management style that is currently called the authentic leadership style? that supports a caring workplace where it's okay to talk about things that are not going well. Unfortunately, we need to be aware sometimes that when a complaint is filed, nothing may, at least on the surface, seem to be being done. Actions may not bring about workplace change. So, we want to move away from putting this all on the individual and saying it's the individual's responsibility to take care of the problem. Well, it's the organization's responsibility to see that the environment isn't there that remains supportive of a bullying culture. I'd like to talk for a moment about contextual intelligence and a term called niche picking. The word niche picking could also be niche picking. That's the idea that, just because things might not be working out for you in a particular situation, if you are the victim or survivor of being bullied, maybe what you need is just a change of scene. Not to leave the profession, but maybe you just need a different workplace environment. Maybe you need to be and to seek out a culture that is not supportive of bullying. If you are, once again, a leader, it's your responsibility to see that you supervise a culture in which bullying is not tolerated. So we come down to some choices. Basically, your choices are to stay in the workplace or to leave the workplace, whatever seems to be the best approach for you. Continuing therapy and support from family and coworkers. And then comes, do you seek redress? Do you seek justice? Or do you choose not to do that, just to stay and end it there? Or to leave and let it lie. So research tells us that we can stay in the workplace, continue and seek redress, stay but not seek redress, leave, seek redress, and leave and not seek redress again. Seek redress or not. You'll notice continue therapy is still listed throughout. And that's because the impact of bullying is not just an impact in this time and in this place. The impact of bullying can haunt us. Once again, the self-discrepancy idea can haunt us. Why did I allow myself to be in this situation? And then some of the family disruption that can happen can reoccur. So you want to continue on taking care of yourself therapeutically and health-wise.
Okay, moving on from the individual to the organizational and unit level, what are the common responses to bullying from organizations and units? And really, traditionally, this is how we have dealt with it. See no evil, hear no evil, and speak no evil. See no evil basically just has normalized bad behavior. We have learned to accept this as business as usual in healthcare. Hear no evil writes off incidents as misunderstandings and personality conflicts. And really, we create a secondary victimization because the targets are blamed. You are making waves. You are making a problem. We've got a lot to do. Get over it. And the next one, speak no evil. Encouraging silence may smooth things over for a while, but they absolutely contradict the fundamental principles of the culture of safety. And really, culture is the level where a lot of this has to be addressed at. The Institute of Medicine defines safety as freedom from harm from healthcare. And how does bullying impact this? If I can give you a couple of simple examples. Let's just say that you have a nurse who has heard through the grapevine that the other nurses don't think much of her skills. They think that she is inadequate. She finds herself in a situation where she needs help. She really doesn't know something, but she's reluctant to ask for help because she doesn't want this to get around to further confirm to people that she's not where she should be in terms of her knowledge and skills. Or another one, that a nurse makes a decision that she should call and consult with a provider about a patient's condition. She calls up the service, finds out that a particular doctor is on call who has a reputation of abusing nurses, and makes a decision not to make that phone call. You know what? No, we'll try to figure this out on our own. Those little things add up and contribute to a real decrease in patient safety, a real increase in harm. Okay, more helpful organizational and unit responses would be to identify known antecedents. Look at your culture, see if these exist. And the antecedents that are associated with bullying in an organization are hierarchies. Do you support hierarchies? Do you have lack of accountability, especially for people higher in the hierarchies? Do you have lack of recognition of the contribution of each role and a lack of reward for the contribution of each role? Another strategy is to provide training for all team members in collaborative behavior, physicians too, and to provide the tools needed by the team to deal with difficult situations with families and colleagues. Really, bullying doesn't just happen between colleagues in the healthcare workplace. Families are also a player in many of the research studies. Another important thing is to provide a balanced approach to outcomes. There's been some very interesting literature come out recently about bullying as a managerial technique when it comes to getting outcomes. An over-focus on these outcomes can unknowingly set the stage for bullying. We can put managers in a no-win situation. And an overemphasis on the bottom line can send the message that this kind of behavior is acceptable as long as the financial goals are met.
And that's where training comes in, Linda. You know, when we talk about the importance of authentic leadership, there are other ways to manage other than bullying and other than management by aggression and oppression. So that idea of let's not take a look at continuing these techniques, but instead move to a more authentic style of leadership.
We hear the word zero tolerance used a lot when it comes to bullying, but what does that mean? What should it mean? What some people assumed when this first came out was that it meant that someone else was going to be punished for treating us badly. And I don't know that that is necessarily the spirit that came behind the recommendations by the Joint Commission. I believe that it meant that this kind of behavior will be addressed every single time that it happens, and that it will be accelerated. But it certainly will not stop with, or start rather, with someone being terminated for one offense.
And I don't think punishment is the answer. I think more a culture in which we examine our own behaviors. Have we stood by and watched someone else been bullied? Especially if we're someone of high status within our workplace, we can do a lot by just moving next to, putting a hand on the shoulder of the person who's being bullied, just to give the signal that you know, I've got your back. It's safe here. I'd also like to comment that unacceptable behaviors, when this turns to this zero tolerance, unacceptable behaviors continue only because they're tolerated, they're reinforced, and they're rewarded. So if we take away that tolerance, we take away the reinforcing of the negative behaviors and the rewarding, we'll get to the true meaning of zero tolerance rather than a punishment process.
And remembering the fact that many of us in the healthcare workplace function in both roles at different times, perhaps the policy that one time and you're coached as opposed to one time and you're out might be a better way to approach it. Yeah. Emphasis on coaching.
Yeah, it's throw in too that the bully in this situation is in a bad place too. And when we talk about zero tolerance, we have to remember due process. Mm-hmm. And we always want to give a chance for all sides to be heard.
So what can organizations and units do to assist victims of bullying? Well, traditionally, we have thought that just making the bullying stop is enough. And really, that's not always the case. If something has escalated to the point where a target is scoring on the post-traumatic stress disorder scale, just stopping the situation is not going to be enough to help them. We need to provide in-depth counseling as needed, maybe add this to the employee assistance program, specific counseling related to bullying. We've got to acknowledge the trauma that people have gone through. You know, in nursing, we tend to really, unspoken values are work around it, buck up, do what it takes to get it done, and sometimes this just will not work when people have experienced bullying. Some institutions have put in hotlines where they can report bullying as it happens, but coaching the perpetrators seems to be the most promising response. And you know, just letting people know that their behavior was felt like bullying to you is often enough to make it stop. As I said before, 70% of bullies don't know it's them. Current national level responses in the U.S. to address bullying in nursing are from the Joint Commission. They issued that disruptive and inappropriate behaviors are now reportable. And everybody may wonder, how do they get involved? How do they know about this? Well, it's very easy. They collect all of the information from root cause analysis on bad errors, on sentinel events, and they noted that over and over again they were seeing evidence of bullying being a factor in bad patient outcomes. Another thing that nursing education is doing is the QSIN initiative, Quality and Safety in Nursing Education, training nurses early on what is a healthy workplace and what is good communication. And I really think that's one of our greatest hopes, is if we can instill this in our new nurses. Okay, what might also be done to assist victims of bullying on a national level? Just some suggestion. Put a little money towards some educational awareness programs, fund some support group networks, fund research on this. There's not a lot of research on what helps nurses who have been bullied. Legislative advocacy to reduce tolerance for bullying, and encouraging those healthy workplace initiatives and components for accreditation, and maybe even for pay for performance. Okay, let's take some questions.
Well, Linda, we have one question so far, and that is, why is there such a problem with doctors bullying nurses? Look, I'll begin, and then maybe if you want to do some follow-up. One of the situations that I see is that bullying can be a learned behavior. We find sometimes that those who have been bullied are those who participate in bullying themselves. So if doctors received in their own training instances of bullying, they may just be practicing this learned behavior. And I also think that it's in a very hierarchical structure, and you talked about that a little earlier. So if you'd like to continue on, Linda.
Well, I think you're absolutely right about it being a learned behavior. There's research out there to suggest that bullying in medical school is horrible, and it's just considered almost as a rite of passage to them. And so, as you say, it's a learned behavior. But I think this also is compounded by the fact that I don't think they really often understand the difference in the role between doctors and nurses, that our scope of practice is really quite different, and there's things that we are better at and there's things that they are better at. For example, research suggests that we are much more effective at teaching patients about managing their health and promoting their health than physicians are. We are much more in tune to palliative care needs of patients than physicians are. We just have a different scope of practice. And I think a lot of times that when they are bullying us, they are doing this thinking about their own scope of practice and things that they would know or that they would do. And maybe some education regarding the scopes of practice would be helpful.
And we don't want to forget that fundamental attribution error. Sometimes we look at behaviors and attribute them to the personality rather than the culture of the workplace.
Mm-hmm.
So are there some things that could be done to change that culture?
It's all about culture, isn't it?
Yes, it is.
Any more questions? I think we're waiting for another question here.
It's just come in. And we encourage your questions.
While we have this little time that we're waiting, I'd like to thank Dr. Wholeben for her collaboration with us, her collaboration with nursing too on our research projects. The National Institute of Health has pointed out the benefits of multi and interdisciplinary research, and also in our activities and quality improvement, we have learned that a set of outside eyes is so valuable when we are looking at ourselves, when we are looking at our own culture. And I just want to thank you for being a friend to nursing.
Well, thank you. And I have in my hands a very interesting question, Linda. When you speak of family involvement, do you mean patients' families bullying healthcare workers?
Yes. As a matter of fact, I think that is more prevalent than patients bullying healthcare workers. Unfortunately, I think patients also often feel that they are at a disadvantage with all of their healthcare providers, that they are over a barrel, so to speak. But families definitely are mentioned in many nursing research studies as being a big source of distress for nurses, particularly with the emphasis now on patient and family satisfaction. Many places live and die by those patient and family satisfaction survey scores.
And we also have to remember the stress that families are undergoing when a loved one is in a serious health condition. But, you know, I imagine there are some patients that and our patients' families who feel that they have been bullied by healthcare professionals. So it sort of goes to show us that it's not just horizontal, it's not just lateral, it's hierarchical. It is in all of the many forms of interrelationships that we have in a healthcare setting.
Absolutely. Okay, so we'd like to end by giving you a little summary of key points that we hope you'll take away. Bullying in nursing is a national problem, really international, with 59% of nurses reporting having experienced it or witnessed it.
National responses to address bullying in nursing include mandates from the Joint Commission and QSEN initiatives to educate nurses regarding behaviors that are associated with a healthy workplace. I think that's so key, to focus on the healthy workplace.
Mm-hmm. Bullying in nursing has been reported in most practice settings and in all levels of practice. And when I say most practice settings, I mean it has been found everywhere we've looked for it. We haven't looked at every practice setting, but every time that we've looked at one, bullying has been noted.
And bullying in nursing is associated with decreased productivity, increased absenteeism, increased burnout, increased turnover, and a cause of nurses leaving the profession.
Bullying is experienced at the individual level, and new nurses are often targets, but there is no profile of nurses most likely to be bullied.
There are identified organizational factors that are antecedents to bullying. Addressing them is an organizational strategy to decrease bullying.
Authentic leadership and proactive team training have been suggested as ways to decrease the incidence of bullying because these impact the culture.
Responses to help individuals recovering from bullying in general include traditional psychological therapies such as individual counseling and family therapy. Organizations can assist victims of bullying by increasing access to these resources.
and more research is needed to determine occupation-specific therapies to help individuals who have experienced bullying in nursing. Thank you so much for joining us. Now, if you would like to get continuing education credit for this presentation, you will need to answer these 2 CE questions. Here is question number 1. List one piece of information that is known about bullying in nursing on each of these levels: national, organizational, or individual. Number 2, list one possible strategy to assist victims of bullying in nursing on each of these same levels: national, organizational, and individual. Your answer should be sent to Nancy Peak at LU-NAN.edu. She will send you an evaluation form, and when you send that to her, she will send you back your CE information. And we also have references and additional resources for you. There's about 7 slides of these. All of these are great resources. We highly recommend them.
Thank you so much to our speakers. And again, if you would like continuing education contact hours, you can send those responses to Nancy Peak at her email. Her email is peekna@louisu.edu. If after reviewing this webinar you have additional questions for our presenters, please feel free to email those questions to alumni@louisu.edu, and we'll be sure to pass them on. Thank you again to all those that have participated in this webinar and all those that have gone to help make this possible. If you would like more information on LU-NAN, you can go ahead and email alumni@louisu.edu or visit alumni.louisu.edu/LU-NAN, LUNAN. And don't forget to mark your calendars for homecoming on October 4th, 2014. As well as our Celebrating Women in Leadership Conference held on the Romeoville campus on October 10th, 2014. Thank you and have a great day.